I've been doing this all inside ACL reconstruction technique for the past 6 years, and I'm here to share a few pointers on how you can get it correct and how you can do it accurately in the first instance itself. So for doing this procedure, you need a few devices. So first is the flip cutter. So the flip cutter which we use is a short flip cutter. It has markings on it at 5mm increments. There is a rubber stop on it which can be used to measure the depth. So essentially, flip cutter is a device which you push the button, it flips, and you can drill to a desired depth as well as diameter. The second instrument is the femoral jig, which is a tip pointer jig for the ACL, and there is a tibial jig, which is a footprint jig for the ACL. Now, these are the bullets which go into the jigs. So the important thing is this step jig, because it is generally hammered inside for about 7mm on the tibial side and the femoral side. The advantage it offers us is it prevents a through and through drilling with the flip cutter, and it preserves the socket. Now for the fixation, as my colleague has described previously, you can use a tightrope RT on the femur on the tibia, or you can use a no button tightrope on the tibia. So generally, I prefer to use the concave button with the no button tightrope on the tibia. The advantage of the concave button is that it has slots in which the no button tightrope can be passed. Now, in addition to the technique described previously, I like to take whip stitch from the tibial end of the graft. So there is one more strand of fiber wire coming on, so which I attach to these slots on the ABS button. So I get a very secure construct with this. Now this is the jig. The other difference you will see that is once you put the flip cutter in the bullet, you can just unlock the jig and remove it, and the bullet stays, compared to a conventional ACL jig. The surgery can be done in a leg hanging position or in a supine position. If you are using a femoral retro drill, then hyperflexion of the knee is not needed. Generally use the standard portals, anterolateral portal, anteromedial portal, and accessory portal. Some surgeons do not feel the requirement for an accessory portal. It's a surgeon choice. Generally, I use it for passing the graft and for retrieving sutures. So the most important thing is when you start the surgery, see the size of the ACL stump, remove all the fat from the area, because this fat can create issues for you later on when you're trying to pass the graft, especially the area around the accessory portal where you need to do a thorough debridement so that there is no impingement from soft tissue. Create the accessory portal through a outside in technique. Then the femoral socket is prepared. So to prepare the femoral socket, we visualize from the AM portal. You can see the bifurcate ridge there. With the help of an RF, it is delineated. Viewing from the AM portal, then there is the femoral jig which is placed inside the joint, and the flip cutter is drilled inside. So the femoral jig has markings which can help you to determine the depth. Once the flip cutter is visualized, you can confirm with a radiograph. Subsequently, the flip cutter is flipped, and then the bullet is hammered inside, as I have told before. Now the flip cutter is activated. So the important thing which we need to understand is, before you activate the flip cutter, you need to measure the depth with the help of the rubber stop. As you progressively drill, you need to drill up till 25mm on the femoral side. So you first start rotating it on the bone, gain RPMs, then pull the flip cutter. Do not directly pull the flip cutter inside, otherwise you may break the flip cutter. Once the socket has been created, generally I prefer around 20 to 25 for the femur. It's like the flip cutter is again put back into the joint. It's unflipped and then withdrawn. At this stage, the bullet is not withdrawn. The suture is flushed through the bullet and then parked onto the accessory portal. Now, this is not how you should use the flip cutter. The flip cutter should always be flipped at 90 degrees angle. If you start reaming at this particular angle, then you will not get a good tunnel. So these are the few pointers. Generally, I keep the femoral jig at 105 to 120 degrees. If the procedure is getting prolonged or if there is a meniscus repair, you can consider using a Gilchrist portal. Visualize the tunnel which you have drilled through the medial portal. The tibial side is far easier compared to the femoral side. Now, a general guide for the socket preparation, it's better to have a longer socket than a longer graft. So why this is important is if your graft is long and the socket is short, you'll get stuck in the surgery. So generally I harvest a graft and quadruple it to around 60 to 70 millimeters. I avoid grafts longer than that. So I put 20 millimeters into the femur, 20 millimeters intra-articular, 20 millimeters into the tibia. For that, I create 5 millimeter extra socket on the femur and 10 millimeters extra socket on the tibia. The tibial side is quite easy. Once you have decided where you want to place the pin, it's placed and flipped. And subsequent drilling is done. Now, the important thing about the tibial side is that the mouth of the tibial tunnel should be kept free of all soft tissues, otherwise it will create an issue. Now, for the suture passage, generally the accessory portal is used and a suture retriever is used to retrieve the sutures into the accessory portal. It's important that we can use a passport in this step. The most important thing is there should be no soft tissue bridging. So use a single pass of the retriever to retrieve the sutures. Now, what if you come across a good remnant like this? So Athlon suture loop is used to shuttle fiber wire pass through the ACL remnant into the femoral socket. The remaining Ethibond suture can be used for graft passage. So the final step in the process is graft passage. So first, through the accessory portal, the graft is docked onto the femoral side, then onto the tibial side. So you can see the pulling sutures are applied. Now, generally the tightrope RT is marked at the length of the depth of the femoral tunnel. You can confirm with an X-ray this particular step that the button has flipped or not. Then the tightrope tails are shortened progressively. The femoral socket is docked, but I avoid docking it completely initially. I dock about 50 to 60% of it. Then I turn my attention to the tibial side. Now you can see that with the help of this suture retriever, I'm retrieving the soft tissue around, especially the remnant. A cinch suture is passed through the no button tightrope, and then it is pulled down to the femoral, through the tibial socket. Only once the entire graft is visible inside the joint, the suture retriever is removed and the graft is allowed to settle down into the tibial socket. This is very important. Otherwise, you can have entanglement. Now, the remaining part of the graft is pulled into the femur, which you can see here. The final tightening is done with the knee in full extension. So the no button tightrope, once it is put over the concave button and tightened, you can check if there is any residual laxity in the graft. If you feel there is laxity, you can again tighten on the femur. So you can get a good tight construct. There are other additional tips. So if you look through the AM portal, you can visualize the flip button. You can see whether your drilling has been correct or not. Generally, the socket should look like this. It should look like a cylinder within cylinder. Now, for passing the graft on the tibial side, this is what I do. So through the free ends of the no button tightrope, I pass this cinch suture. So the free ends of the cinch suture are then fed onto the tibial loop and then taken into the joint and then to the socket. Do not directly try to put the no button tightrope into the socket. It can lead to premature shortening of the device. So this is what I've discussed till now. Now, with regards to tensioning and fixation, generally I prefer fixation in full extension because this is a construct which does not slip over a period of time compared to bioabsorbable screw, which can slip over a period of time. So that's why those devices are fixed at around 30 degrees of knee flexion. It's important to dissect the soft tissue down to the entry point of the flip cutter where the concave button will sit. Preferable is to use the 14 mm concave button because it has 2 holes in addition to 2 slots. So the slots are used for fixing the no button tightrope and the holes are used for passing the fiber wire sutures from the whip stitch. First, the fiber wire sutures from the whip stitch are passed through the holes so that the concave button doesn't fall down. This is one problem sometimes you may encounter while putting the button. So use a needle holder to hold the button and then implant it. First put the fiber wire through the holes, then tighten the no button tightrope. Once this is tightened, check the tension arthroscopically in the ACL graft. If you feel it is loose, you can additionally tighten on the femoral side. Then finally, the fiber wire, which was the whip stitch, is tightened. So these are some new innovations that have come. So essentially it's the Flip Cutter 3, which is adjustable, and you can have various drill diameters on this. And the second one is the Tightrope 2, which has fiber tape instead of fiber wire. So I think somebody from Avana will be speaking on this later on, but generally from what I've heard, this will be introduced in India maybe by this month end. Thank you.